So I'll share my slides here. So this is a talk that I started giving last year. And we focus on a lot about the, how to put in coronary stents in training, but the talk today is kind of about the why, and why do we use coronary stents and why do they exist in their current form. So I have a disclosure that's not directly relevant to this material. So my objectives today, I'll give a brief overview of the history of angioplasty. I'll describe the advent of bare metal stents and then mechanisms of bare metal stent failure, which then led to the development of drug-eluting stents. And then 3 areas that I'm going to stay away from because they're, I think, separate topics on their own, deserving of at least an hour-long talk, which are antiplatelet therapy, intravascular imaging, and then drug-coated balloon angioplasty. So in this first section, I'm just going to briefly overview the history of angioplasty. I think both from an interesting, it's both interesting just from a historical perspective, but also kind of helps inform our current practice. So just as a timeline, just to put it all on one page. So if the first use of angioplasty for coronary arteries was in 1976, the first FDA approval of coronary stents was a bare metal stent in 1991, which was specific for to prevent emergency bypass surgery after balloon angioplasty. And then really, in the next 30 years after that, it's kind of brought us up to where we are now. So I'll start off with just a brief trivia question. Obviously in Zoom, it's kind of hard to answer this, but this is somebody who's kind of instrumental to angioplasty as we know it. So who is this? If somebody wants to unmute and jump in, that would be great. Otherwise, I'll just give the answer in a second.
Charles Dotter.
That's right, Dr. Sitaro. So Dr. Sitaro is the historian of the group. And so I'm not surprised that Dr. Sitaro was all over this. So this is Charles Dotter, who actually performed the first angioplasty. So he was an interventional radiologist at Oregon Health and Sciences University. And so was seeing a patient with critical limb ischemia, and he had been kind of, debating this idea of how to endovascularly open blood vessels. And so dottering, which is a term that we use in the cath lab quite a bit, is essentially serial dilation of lesions. And so Charles Dotter had dilators that would go up to 9 French that he would insert through these blood vessels. This is a superficial femoral artery, and this woman, Laura Shah, who had critical limb ischemia, was deemed not a surgical candidate and was told that she had no options. And so in that circumstance, Charles Dotter performed the first inhuman angioplasty, where he used his dottering technique to open up that blockage. And then on a surveillance angiogram, 30 days later, the blood vessel was still open. And this was really kind of the first idea that you could open a blood vessel from the inside without having to use a surgical technique to revascularize the patient. So based on Dotter's success, Andreas Grünzig, who was in Switzerland at the time, essentially said, this is a great technique. But the limitation of dottering was that the lumen that you would get from the catheter was related to the size of the catheter. And so Grünzig said, if you can put a balloon onto a catheter, you could essentially get a larger luminal gain than the size of the catheter itself. So Grünzig and his wife, Michaela, handmade balloons in their kitchen. They would tie a piece of plastic to a catheter, essentially making surgical knots on them to hold the balloon in place. And then this is the first demonstration of an angioplasty in a human where this is, again, a superficial femoral artery where Dr. Grünzig was able to open this superficial femoral artery, which was severely diseased, and then had significant luminal gain afterwards. Grünzig then took his success with peripheral angioplasty to coronary interventions. So on the left, you see one of the first coronary angioplasty catheters. And so essentially there's a stopcock connected to a syringe. and then another stopcock that could be used to measure pressure through this catheter. And then on the right, you see essentially other balloon-tipped catheters that Dr. Grunzig had made. Actually, these catheters, like I said, were handmade. They would use sandpaper to narrow the tip a little bit to make them more amenable to crossing lesions. But really, these were kind of rudimentary, and this was really the first concept that this could happen. So balloon angioplasty was very novel in that era, but had significant limitations. So as this became more useful clinically, there were significant limitations. And so the first is kind of an acute problem, which is acute vessel closure. So between 4 and 10% of patients, 4 and 10% of patients would experience acute vessel closure, which was related to elastic recoil and or dissections of the vessel. People who had abrupt vessel closure would have a high rate of MIs, up to 40%, and then up to 20% of those patients required emergent CABG. So a very morbid complication and kind of directly related to the intervention that was performed. And then a more long-term consequence was restenosis. So between 30 and 50% of patients would develop restenosis, often within 6 months. And so in a year, the average target lesion revascularization was 20 to 30%, which is incredibly high for a device therapy in the current era. This picture at the bottom kind of shows that process of what happens. So if you have a diseased vessel in cross section here, you have a lumen that has atherosclerotic plaque in it. It undergoes balloon angioplasty. So you have, in the acute setting, you have significant luminal gain, but then you have elastic recoil, which happens almost immediately. And then over time, you have neo-intimal formation and restenosis. And so again, narrowing the lumen almost back to the way it started. So another trivia question. Another figure that's very important to this idea of stenting. So Dr. Sitaro.
Dr. Stent.
That is, it's not you.
Charles Stent, an English dentist.
That's right. So coronary stents, as we know them, the term stent actually came from Charles Thomas Stent, who was a dentist. Dr. Stent took a compound called gutta percha, which is actually still used as a medical filler, derived from a plant that grows in Southeast Asia. And then he added glycerin and stearine and a few other things to it to make it a little bit more firm. And so that was his first concept of essentially taking this compound and using it in a biological sense to hold things open. So then in the urological literature, this is kind of the first use of the medical term stent when talking about keeping ureters open. When referring to an intraluminal device to maintain patency until healing has taken place, the word stent is most appropriate. And so that kind of set the stage for the word stent as we use it now. So vascular stents were initially, this is kind of a repurposed biliary stent. And so in the 1980s, this wall stent was developed, which is a stainless steel filament, which is a self-expanding stent. And then after using them in non-vascular structures, they were then used, again, initially in the superficial femoral artery. In this figure in the middle, you see an angiogram, then you see the radiograph without contrast, and you see actually 2 wall stents. The problem with wall stents were that it had a 5 French delivery system. It had to go through an 8 or 9 French guide. And even with that, they could only go up to 6.5 millimeters. And so really a very bulky device. And so this was kind of an early generation of what stent technology was going to have to offer. All the way on the right, this figure, you see angioplasty at the top of the screen. And then this was a patient who suffered abrupt vessel closure, and then a stent was placed, which then reopened the blood vessel. And this was the initial publication of the use of a stent for human coronary arteries. Early on, looking at the outcomes of the wall stent, and so this was actually considered a very positive study. So in the first 2-year experience, it was 105 patients and 117 stents. So they had a 67% patency rate at 2 years, both when you count by the number of stents and the number of patients. But if you actually look at this data a little bit closely, so every patient had a 30-day follow-up angiogram unless they either refused, had an inadequate study, or died before that could happen. And so 23% of the stents were occluded, which is really, in the current era, it's an abysmal rate of stent occlusion to have it 30 days. But at that time, this was kind of still a very promising technology. If you look at 1 year of follow-up and the proportion of people who did not have an event, by 1 year, more than 50% of people had an event, which was death, occlusion, and restenosis greater than 50%. So really, this was an early trial of a promising technology, but still had a lot of work to do. So building on the success of the wall stent, the Palmaz-Schatz stent was developed, which was a balloon expandable stent. This actually was an improvement over the wall stent for a couple of reasons. So one is that you could essentially get a larger diameter stent on a smaller device because this was balloon expandable. And then the other is that the initial version of this stent was a rigid stent that had to be crimped onto the balloon and was very bulky and difficult to deliver. And there's, I think, a few people on this call who have actually used these stents and can attest to this. And then the next iteration was this articulated stent where there was essentially this stent scaffold and then a link connecting them in the middle. So this could articulate and actually better travel around bends to be delivered. So again, the Palmaz-Schatz stent, kind of as I mentioned, so improved delivery, better expansion, where it could go 6-to-1, which is kind of similar to what we get with current era stents. But they found early on that without anticoagulation, 18% of patients had acute stent thrombosis. And so patients actually had a very intensive anticoagulation regimen, both with aspirin, dipyrimidine, Coumadin, Dextran, and there's a whole host of measures that were taken to prevent acute stent thrombosis in this early era. The first FDA approval for a coronary stent was actually the Gianturco-Rubin stent, which was specifically for this indication of preventing emergency bypass surgery after balloon angioplasty. This stent developed by Gary Rubin was a suture wire that was actually wrapped on a balloon that was in diameter 0.5 millimeters larger than the intended diameter of the stent. So you can see it's almost like a spring that was effective for this one indication that it was approved for. And then there were 2 pivotal trials of bare metal stents, both published in 1994 in the New England Journal of Medicine. So the European study was the BENESTENT study, which was looking at 520 patients with stable angina who were randomized either to balloon angioplasty or the Palmaz-Schatz stent. All patients received this intensive anticoagulation regimen with an INR of 2.5 to 3.5 is the goal after the stent was implanted. And what they found is that over 7 months, there was a significant reduction in repeat interventions with stents. And so if you're looking at this, this graph, the clinical endpoints are on the y-axis, and then on the x-axis, this is time. So going to 7 months, the angioplasty arm clearly had more clinical events than the stent group, although the stent group still had about 20% restenotic or representation events. And so this is, again, another table showing the same, that still 20% of patients had some sort of adverse outcome, but this is still better than the angioplasty arm. Of note, with stents as compared to balloon angioplasty, the length of stay was 8.5 days for patients who received a stent and 3.1 days for patients who had angioplasty. This had to do with larger vascular access sites, more bleeding complications, and then again, this anticoagulation regimen to get people anticoagulated So there were significantly more vascular access site complications in the stenting arm related to that. I think from our own experience here for people who participated in that trial, what I heard last time when I gave this talk is that patients would actually get sent to the New Haven Hotel to be bridged to Coumadin so they could be appropriately anticoagulated. So then the United States arm of this study were essentially a similar design looking at a randomized trial of bare metal stents and balloon angioplasty, the STRESS study, published at the same time in the New England Journal of Medicine. So this looked at 20 American sites, and it was to compare the rates of restenosis at 6 months. So 410 patients were enrolled who had stable lesions greater than 70% stenosis. This was all angiographic analysis, not with any intravascular imaging. So if you look at this figure, at baseline, it shows what the minimal luminal diameter was that was measured by QCA. And then after the angioplasty, they had significant luminal gain. So the stent arm is this line that's all the way to the right where they had the most luminal gain. Balloon angioplasty also had a significant luminal gain, but then in follow-up, both of those regressed a little bit, but stents continued to have a greater luminal gain than balloon angioplasty. And then looking at patients requiring repeat revascularization, again, at 6 months or less than a year, people with stents, this was nearly significant, had a lower rate of reintervention compared to angioplasty alone. So these were both considered positive studies for stent placement. So with that data that was supportive of using stents for coronary interventions in stable patients, stents became a little bit more widely used, but they still had some challenges. So one was subacute thrombosis. And so Dr. Fa will talk about the use of intravascular ultrasound and how high pressure post-dilatation became routine after some pivotal IVUS studies. But there was initially this aggressive anticoagulation regimen, which was then refined to being aspirin and ticlopidine, and eventually Plavix, similar to what we use now. And then there was restenosis that happened within a few months after stent placement. So I'll just kind of show some cross sections of what this problem is. And so all the way on the left, you have a vessel that's undergone balloon angioplasty. And then in the middle panel, you have a vessel that has a stent in place. You can see the stent struts kind of at the edge of the intima. Comparing the stented vessel to the balloon angioplasty vessel, you see that there's a significant intimal formation within the lumen adjacent to the stent struts. And then on this higher magnification view, you can see that there's significant tissue growth here right around the stent struts. And so this became kind of a major problem. So more figures of just restenosis. So an angiogram here showing a patient who had 2 Palmaz-Schatz stents that were overlapped. This is in the circumflex. You can see the stents here. This is a patient that eventually passed. And then on autopsy, you can see the stents in the vessel. And then on cross-section, you have stent struts. This is the overlap segment where there's 2 stent struts adjacent to each other, and very significant neo-intimal hyperplasia at that restenosis. And so this was clearly a problem with this technology, and was really the Achilles Achilles heel of bare metal stents. So restenosis, just as a disease process, it's a local vascular inflammatory response to injury. And so there's 3 parts to it. So the first is early elastic recoil, similar to what we described with balloon angioplasty. Second is late vessel remodeling. And then the third part is neo-intimal growth or hyperplasia. So the initial trials to try to reduce restenosis relied on coatings such as gold and heparin. So these actually, in some cases, were worse. This was a study that looked at gold coated stents versus stainless steel stents. And event-free survival was actually worse for patients who have gold coated stents. And so these initial strategies were unsuccessful, which then led to the advent of drug-eluting stents. So One more word on the pathophysiology of restenosis, and then we're going to go to the next section on drug-eluting stents. So with bare metal stents, the stents would be put in the setting of a stable stenosis. There would be arterial injury, activation of vascular smooth muscle cells, and then proliferation and migration of vascular smooth muscle cells and extracellular matrix formation, which would then lead to restenosis. There's also significant macrophage infiltration of these, and then also some thrombus that would get incorporated. So the whole point of drug-eluting stents is that you try to inhibit this proliferation and migration of vascular smooth muscle cells. And that's where these anti-proliferative coatings came into play. And so essentially using drugs to stop the cell cycle to prevent restenosis was the idea behind drug-eluting stents. So in the next section, we're gonna just briefly go over drug-eluting stents and taking us up to where we are today. If anyone has questions, please feel free to jump in anytime. So some of these slides have been taken from the CV Path group, which is a pathology organization that specializes in cardiac interventions and has really been instrumental in kind of describing the problems that have occurred with stents. And so drug-eluting stents, so they've had a few kind of goals. So one was, improved design and materials compared to bare metal stents. This coating that required both a polymer and a drug. And so the polymer essentially would hold the drug in place on the stent scaffold and then would have a certain elution profile to let the drug release at a certain rate to prevent restenosis. So I'll show a few figures of this to kind of describe the current era of drug-eluting stents. So if you take this bare metal stent, which was, these are stainless steel scaffolds where you have a piece of metal, stents would then be coated with an anti-proliferative agent with a polymer. Some of these polymers are abluminal where they're only on the outside of the stent. And then some are coating the entire stent strut. And then essentially the polymers have certain characteristics that allow the drug to elute and actually interact with the vessel to prevent restenosis. So Xience, Promus, they have an everolimus durable polymer, which releases over 4 months. And then Resolute has a polymer that releases 85% within 60 days or 100% within 6 months. And then there's stents like Synergy or Siro who have a biodegradable compound, which actually just completely dissolves over time. So the biostable polymers that I mentioned were Onyx, Promus, and Xience, whereas the biodegradable polymers are Synergy and Siro. I'm going to stay away from the specific drugs because in some senses they're similar and others they're a little bit different. But I will talk a little bit about early generation versus current generation. So the polymers, like I talked about, they're ideally biocompatible. They don't interact with the active drug that's being eluted. And then they provide a platform for appropriate drug-eluting kinetics that are favorable for patency. So the first drug-eluting stent was a Sirolimus stent. And so this was the Cordis BX Velocity stent in 2001. And so this is a stainless steel scaffold with 150 micrograms of Sirolimus per stent. And so the initial proof of concept study in 2001, so essentially looking at restenosis within 8 months of follow-up and essentially really trivial neointimal hyperplasia. And so these were, this was a good sign at first that this was going to be a good technology. Pathological analysis showed that in a bare metal stent on this top figure where you have really significant neointimal hyperplasia at 15 months as compared to a drug-eluting stent where you have your stent struts and really no neointimal growth at all, showing how successful these were. For in-stent restenosis, at 15 months of follow-up, drug-eluting stent was significantly lower compared to the bare metal stent, and same with the thickness of the neointimal, showing how it was measured. This is a meta-analysis in the New England Journal of Medicine looking at the first generation drug-eluting stent trials. So the dark lines are bare metal stents. And if you look at the rate of angiographic restenosis, bare metal stents were higher in every study. And so the relative reduction in risk for drug-eluting stents was pretty significant compared to bare metal stents. But despite that, there was a few years in with the first generation of drug-eluting stents, something called the ESC Firestorm. And so there was this headline that came out of the European Society of Cardiology meeting that essentially said, do drug-eluting stents increase deaths? And so this was based on two meta-analyses that were published at the same time, one in the New England Journal of Medicine and the other in Lancet. And this was really a provocative article that jumped into the press, and patients who had stents were then worried that they were going to be at a higher risk of death. And so despite having a lower incidence of restenosis, stent thrombosis became a big concern. And so this was just one snapshot of this. And it's actually, if you read this, it's pretty provocative. So first, it starts off talking about a possible increased risk of thrombosis with early generation drug-eluting stents. But that also says Yusuf widened the debate to include PCI. The overuse of PCI is an insidious change in the culture of cardiology that needs to be reversed. And so some of the criticism that we still hear, so the use of PCI was established in MI, high-risk unstable angina, and cardiogenic shock. However, its use in stable disease was a totally different question. So just to show those meta-analyses. So I mentioned before that there was this significant reduction in restenosis and TLR. The number needed to treat to prevent TLR for early generation stents was 7 or 8 as compared to bare metal stents. And that was kind of the positive. But then the negative that came out of these meta-analyses is that there was a signal of higher stent thrombosis for both Sirolimus and paclitaxel drug-eluting stents, so the Cypher stent and the Taxus stent. So between 1 year and 4 years after the procedure, patients with bare metal stents for Cypher stents had no episodes of stent thrombosis. And then with bare metal stents compared to the Taxus stent, there were 2 patients, but 9 patients in the Taxus stents who had stent thrombosis. So despite being successful at preventing restenosis, there was still this signal of late thrombosis that was poorly understood at the time. This is from a slide that Marty Leon presented at TCT in 2007 that kind of summarizes this. And so this was a real signal. So looking at a total of 5,000 patients, this late stent thrombosis, which is the yellow part of this bar graph, was significantly higher in patients with this first generation of drug-eluting stents. And then on the bottom, it's bare metal stents, where there was really just a low incidence of late stent thrombosis. So the pathophysiology of late stent thrombosis was thought to be multifactorial, so related to both a lack of post-dilation at the time of deployment, high-risk patients with problems with antiplatelet compliance and or resistance to antiplatelet therapy. This was in the era where there was only Plavix. And then there was some thought there was a drug effect related to the anti-proliferative compound. So again, pathologic analysis of patients who had stent thrombosis essentially showed that patients who had this first generation of drug-eluting stents had impaired endothelialization of the stents. So this is looking at the amount of endothelial coverage of the stent struts. And so you can see drug-eluting stents were significantly lower, essentially at all time points, going out several years compared to bare metal stents, which endothelialized fairly quickly within a couple of months and then maintained more than 90% endothelial coverage. This is a cross-section of a patient who actually died of stent thrombosis. In the proximal part of the vessel, you have a Cypher stent, and then in the distal part, you have a near stent, which was a bare metal stent. The Cypher stent, if you look at panel C, you see the stent struts almost coming out into the lumen because there's such little coverage with endothelial cells over these, whereas the near stent has neointimal growth, but there's significant endothelialization of it. And so this was one problem with early generation drug-eluting stents that was thought to contribute to their thrombogenicity. So again, another picture, another cross section where you see a Cypher stent, stent struts essentially coming out into the lumen with very little intimal coverage. In vitro studies show that very early on you would start to get thrombus formation around these stents. So these had fibrin deposition, and then essentially, there would be a stent thrombosis event related to this. In contrast, a bare metal stent had, again, significant neo-intimal hyperplasia, but really well covered by endothelium. So histological studies also showed an inflammatory response to early generation drug-eluting stents. And so this is postulated to be secondary to the polymer that was used. So Taxus stents were more likely to cause eosinophilia, which you see in this top figure. And then Cypher stents were more likely to be associated with giant cells. And there were actually case reports of hypersensitivity reactions and then aneurysmal remodeling of vessels related to this. So based on that, the initial problems with the first generation of drug-eluting stents, the second generation actually had significant improvements. So this schematic kind of shows the problems with stents and the desired outcome that you want with a stent. And so if panel A is a bare metal stent where you have excessive neo-intimal hyperplasia, panel B shows the problem with drug-eluting stents where you have delayed arterial healing, which lasts years and leads to this increase in stent thrombosis. This OCT image shows uncovered stent struts. And then an appropriate stent response, and this is kind of what was desired with second generation drug-eluting stents, was that you would get physiologic arterial healing where you have your stented vessel, intimal coverage without really excessive intimal hyperplasia. The biggest feature of second generation drug-eluting stents is that the stent struts were a lot thinner. So Cypher and Taxus stents were essentially a very thick scaffold. So the struts were 140 microns for Cypher and 132 microns for Taxus, whereas the second generation, the Endeavor and the Zion stents were 91 and 81 microns respectively. This was known early on that thinner struts would lead to lower restenosis. And so this was essentially a head-to-head study of just thin struts versus thick struts, showing that restenosis, both angiographically and clinically, was lower with a thinner strut. In vitro assessments of this showed that you would essentially get essentially changes in flow around thick stent struts. And so if you're comparing this thin strut, which was 81 microns, compared to a thick strut, which is 160 microns, you'd get increased thrombogenicity because of the thick struts. You'd get these eddies in flow related to this thick strut, essentially sticking out into the lumen, which would lead to actually thrombus deposition on their in vitro model in this study. So second generation drug-eluting stents fixed a lot of the problems with first generation drug-eluting stents. And so I'll show a little bit more data about this, but basically, if you look at a first generation drug-eluting stent going out several years, it had the highest risk of stent thrombosis, which is at least 2%. Bare metal stents were somewhere in the middle, and then second generation drug-eluting stents had the least risk of late stent thrombosis. This was a meta-analysis that was actually just published in CCI this month. So two key endpoints. So one was target lesion revascularization at 1 year, and then 5-year very late stent thrombosis. Had significant improvement with thinner strut or second generation drug-eluting stents compared to early generation drug-eluting stents. So looking at first at 1 year target lesion revascularization, you can see that thick struts had the highest risk of TLR. There's a few stents that stuck out here, which are thin struts, but overall the trend was that these second and third generation drug-eluting stents with thinner struts did better than these early generation drug-eluting stents. And then for 5-year late stent thrombosis, you can see that there's this big clustering of these early generation stents where there's late stent thrombosis, whereas this is something that's not really seen nearly as much with current generation drug-eluting stents. So the current technology, if you compare it to the technology that was available with first generation drug-eluting stents, so in the first generation, you had a stainless steel scaffold, you had thick struts that were 140 and 132 microns, either sirolimus or paclitaxel were the drugs, and then these polymers that were thought to be not very immunocompatible and caused these inflammatory responses. The second generation of cobalt chromium alloys or platinum chromium alloys had thinner struts, and then different drugs, Sirolimus or everolimus, and then different types of polymers that are thought to be more biologically inert. This figure actually shows the coating of the polymer around the stent strut, so that's the red line. So all three of these, so both Resolute stents, Giant stents, they have a coating all the way around the stent. And then Onyx, which is our current era stent, which is a cobalt chromium alloy with a platinum iridium core, 81 microns, and then a Sirolimus drug. And then the biodegradable polymers. So those are Orsiro stents, which is an ultra thin stent, it's 60 microns. And then that polymer actually breaks down completely at 15 months. And then after that, this is essentially a bare metal stent. Synergy is similar. So after 4 months, the Synergy is essentially a bare metal stent. Synergy is unique because it has an abluminal coating, so it's only on the vessel side of the strut. So the other part of the strut is actually uncoated. And again, Synergy is relatively thin strut at 74 microns. One thing I'm not going to focus on very much is actually the scaffold itself. And so there's a lot of work being done on the stent scaffolds, both in terms of deliverability, radial strength, and then now for bifurcation lesions is, how do you design a scaffold that can be used in any vessel for any purpose? And so there's a lot of different technological advances in these. The design of them, some of these are essentially like the Onyx, I'll show a figure is one woven coil, and they have certain links that are connected, and that's what holds the stent together. Synergies are laser cut scaffolds, and so there's a lot of engineering and technology that goes into these stents. This is an ad for an Onyx stent, and so essentially shows that you have this wire that is essentially wrapped and then fused together at these links. And then that makes the stent scaffold itself. And then in terms of the actual components of it, it has this cobalt chromium shell, as they call it, and then a platinum iridium core, which makes it both strong and visible radiographically. So current generation stents have really been outstanding in terms of the clinical outcomes that we look for, and this was driven by clinical events with bare metal stents and early generation drug-eluting stents. If you look at a Cypher stent that had very thick struts, you have a significant inflammatory response around the stent. As compared to a second generation Zions, where you have a thinner scaffold, this is kind of mirroring that figure that I showed of just kind of an optimal result for what you would want for a stent, where you have this thin layer of intimal coverage without significant intimal proliferation. And you see the same thing with the Zion stent, where you have the stent struts, a thin layer of intimal coverage, but either way, a preserved lumen in both cases, which is significantly different than what was seen with that Cypher stent. Bioresorbable stents were developed to essentially preserve vascular function and prevent late lumen loss. And so there was a lot of excitement about these several years ago. I think Dr. Adaran was the site PI for the Absorb 3 trial, which we were a site for. And so the OCT images here and the cross sections will kind of show what was desired for this. And then unfortunately, it didn't pan out the way that it was hoped. So if you look at this cross section of a stent strut in this vessel, you see that early on you have this scaffold, and then it starts to break down, and that by 3 years it's completely gone, with the hope that you would essentially have a normal vessel in terms of vessel mechanics after the stent scaffold is gone. If you compare that to a Cypher stent, which stays in the blood vessel forever, which led to this late thrombosis signal, you can understand why this was desired and initially developed. The problem was that these bioresorbable stents had an extremely high stent strut thickness, 164 microns. And so there was an early signal of stent thrombosis, which is this blue line here, compared to the Xience second generation stent, which was the comparison arm. And it actually persisted and actually got worse over time. Some of this was thought to be related to the way that these stents were implanted. But overall, it was a hazard that never really went away. And so bioresorbable stents kind of fell away based on the data of these absorbed trials, which showed this increased risk of stent thrombosis. So the current state of the art are these ultra thin strut bioresorbable stents. And so we've seen study after study showing superior outcomes with ultra thin strut drug-eluting stents. So the BioFlow 5 trial looked at Orsiro drug-eluting stents from Medtronic versus Xience. So Orsiro was superior to Xience for both target lesion failure and target vessel MI at 2 years. So this is a central figure from a JACC paper from 2018 looking at that. And you see both at target lesion failure at 2 years, target vessel related MI, ischemia-driven target vessel or target lesion revascularization, target vessel failure, and then stent thrombosis. This is essentially a head-to-head of a third generation stent versus a third generation stent, but the ultra thin strut really came out on top. And so you have incredibly low rates of clinical events in both arms, but really stent thrombosis was less than 1%. So for a device that's being put in, I think this was a big success, showing that both devices were very safe, but the ultra thin strut stent really overcomes some of the problems with both bare metal stents and then early generation drug-eluting stents. Yasin Hussein and Dr. Lansky and their group did a meta-analysis of these ultra-thin strut stents, comparing ultra-thin strut stents versus second generation drug-eluting stents. And so you can see that ultra-thin strut stents essentially in every study have come out on top compared to second generation stents. And so this is looking at 2-year target lesion failure or target lesion revascularization. And these ultra thin strut stents are really going to be the future of coronary stents. So I'll take any questions and I'll conclude there. So just my final thoughts are that over the last 40 years, there have been tremendous advances in percutaneous coronary interventions, and stent technology has really been this incredible success story that's been driven by clinical events and innovation related to that. If you consider the context of seminal trials in cardiology, Courage was published in 2007. The overwhelming majority of patients received bare metal stents. In the last 6 months of enrollment of Courage, patients received Cypher or Taxus stents. Even in the ischemia trial, I think 98% of patients received drug-eluting stents, but interestingly, only 93% of patients in the PCI arm even received stents, so there was 7% who didn't. And then I think, looking forward, routine use of intracoronary imaging, shorter durations of dual antiplatelet therapy, and thinner stent struts are all going to lead to improved PCI outcomes as we go forward. So thank you very much, and I'll take any questions.
So Samit,